Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program, we're going to learn a little bit more about stroke awareness. And we're lucky enough to have with us today Dr. Michael Markowski, who's the Cape Cod Hospital Stroke Program Medical Director, and Pauline Philie, who is the Cardiovascular Quality Department Manager and Cape Cod Hospital Stroke Program Coordinator. Thank you both for being here.
Thanks for the invite.
Thank you very much.
I'm just going to put another little plug in for you that Dr. Markowski is also the staff neurologist with Emerald Physicians Group and the vice chair of General Neurology section of the American Academy of Neurology.
Correct.
Very good. Thank you. Yeah. So, stroke. Before we get on the good stuff, I always like viewers to sort of get a little knowledge about who you are, how long you've been here, how did you get here, and some fun factoids like that.
Sure, absolutely. Well, first off, thanks for the invite during May, which is Stroke Awareness Month. So Pauline and I are always happy to chat and spread the word for stroke awareness. So I've been on the Cape for about 7 years now. So I'm a neurologist with Emerald Physicians. And for a little over 6 years now, I've also been the stroke director at Cape Cod Hospital. So with Emerald Physicians, I'm in our North Street office in Hyannis, but Emerald has offices ranging 8 or 9 different offices now from Mashpee to Brewster and Harwich. So over the next few months, our neurologists will be in some of these other offices as well. So in addition to being a neurologist with Emerald, also cover the hospital on a regular basis, and as we'll talk more about today, stroke is very common on the Cape. So it's been it keeps Pauline and I very busy in terms of our stroke prevention and stroke management.
That's great, yeah. I imagine the population lends itself.
It sure does. Stroke is like many vascular diseases, is more prevalent in the older population. And here on the Cape, we're an aging community. Now that being said, about a third of all strokes occur in people less than 65. So this is not just with our Medicare population.
Right.
Yeah, correct.
Well, Pauline, I want to check with you. How long have you been on the Cape and in your role?
I've been a nurse, a cardiovascular nurse, critical care, for about 35 years, and I've been at Cape Cod Hospital for 25 of those years. And
so you started when you were 10?
I started when I was 10, thank you for that. And I've been working closely with all of the cardiovascular programs at the hospital, the cardiac programs, and since stroke is a vascular disease, stroke is part of our cardiovascular initiatives.
Okay. So just out of curiosity, because I always wonder how people take the path that they do, why stroke? Is there a personal interest or experience that brought you down that path of? Well,
as a community neurologist, I see a lot of stroke, especially here on the Cape, where in general we're an aging population. At Cape Cod Hospital, we will see 70 admissions a month with patients with strokes and TIA symptoms, warning signs for stroke. So number one, stroke is very common, far too common. Number two, stroke is a very debilitating disease. As we'll talk about more, it's the number one cause of disability in adults. And then lastly, being a vascular disease, a disease of blood vessels related to risk factors such as high blood pressure, high cholesterol, diabetes, and smoking, stroke should be largely preventable. So really those three reasons are why I've become more interested in stroke and helping in any initiatives that I can.
Okay. Pauline?
Well, likewise for me, working in critical care, that was my first nursing experience out of my college program, and just witnessing the impact that stroke has, cardiovascular disease overall, but stroke particularly. I think stroke is close to being, if not being, the number one disease people fear the most. And that, the thought of being disabled, the thought of being so completely dependent on others, and to be that burden to others, supporting patients and their families through the crisis of stroke and intensive care really, again, just brought a passion within me to commit myself in that direction.
Nice, yeah. Well, we're lucky to have you on the Cape doing that kind of work. It's such a popular thing.
We're happy to be here.
So for viewers that maybe the terminology of a stroke gets tossed around loosely,
sure.
Do you want to talk about what is a stroke exactly?
Absolutely, Jeanne. So stroke is brain injury related to an abnormality of blood vessels. So the vast majority of strokes, about 85%, of what we call ischemic stroke, related to a lack of blood supply to the brain. The other 15% is what we call a hemorrhagic stroke, or bleeding into the brain itself. So in terms of the ischemic strokes, we're talking about blockages in blood vessels either in the large arteries of the neck, the carotid arteries, or the larger or smaller arteries of the brain. And that's treated very differently than bleeding into the brain or hemorrhagic stroke, which is typically related to uncontrolled high blood pressure, head trauma, or sometimes aneurysms, abnormalities of the blood vessels, which can rupture.
So if somebody had going back to the injury, so if you, the hemorrhagic would be if you bumped your head or had a fall.
Correct,
or something like that.
Sometimes just with uncontrolled high blood pressure, these blood vessels with time will rupture when they shouldn't otherwise. So that would cause bleeding into the brain, opposed to ischemic stroke where we're talking about a blockage somewhere. And some of those blockages are related to plaque buildup, just like a heart attack would be plaque buildup in the heart arteries. A lot of these ischemic strokes are plaque buildup in the brain arteries. And that can be related to a local plaque buildup related to atherosclerosis, or a unique risk factor for stroke would be atrial fibrillation. And that's an irregular heart rhythm, where the heart doesn't beat in synchrony, the different chambers. It's a very irregular heart rhythm. And because of that, blood clots can form within the heart. And if those blood clots travel through the blood vessels and block a blood vessel in the brain, that's what we call an embolic stroke, where there was a clot that traveled from somewhere else.
So basically, the stroke, as a sort of a general rule overall, is all about the brain. Even though things happen, it comes from someplace else within the body, it ends up here, and that's what causes all the trouble.
Stroke relates to brain injury.
Okay. Now, how common is it? There's all kinds of factoids out there.
You know, had been the third leading cause of death in this country. Only recently the statistics were revised that lung disease has taken that spot. Really? Unfortunate for those. But stroke, again, still holding that fourth leading cause of death in the country. And stroke, as we mentioned earlier, is the number one cause of disability, which again I think is probably the greatest impact on the individuals, the person as well as the family that's then trying to support that individual. At Cape Cod Hospital, when we started as a primary stroke service hospital with the Mass Department of Public Health program, we were seeing about 30 strokes a month. They expanded the population that we need to report on, and now we're seeing above 70 cases per month, and that's stroke and TIA, as Dr. Markowski mentioned, including within the stroke group the hemorrhagic population. But 70 a month, again, is pretty astounding for, you know, a hospital our size.
And that's just at Cape Cod Hospital in Hyannis, and there's additional numbers at Falmouth Hospital.
That's Hospital.
And on a national level, it's over 800,000 Americans every year are affected by stroke or TIA.
Men more than women? Or?
Correct, yeah. There are some treatable and some non-treatable risk factors for stroke, and age and gender are some of the non-modifiable risk factors. And men do have a higher risk of stroke compared to women. And also with age, every decade over 55, your stroke risk doubles.
Really?
Absolutely.
Wow.
But again, it's not just a disease of aging. About 30% of all strokes will occur in people less than 65.
Wow.
Then there's a few other non-modifiable risk factors, ethnicity and heredity. So African Americans and Hispanics have a higher risk of stroke than Caucasians. And if you have a family member, a first-degree family member, a mother or father in particular, who had a stroke, then your stroke risk is doubled as well.
Is the risk from the heredity because of the high blood pressure that came with it, or something like that?
Oftentimes that is exactly right. Oftentimes because high blood pressure and high cholesterol can run in families as well, not to mention type 2 diabetes or adult onset diabetes, which is a risk factor for stroke.
So for viewers to understand, I'm sure they are familiar with either friends or neighbors, family that have had a stroke. And I know, Pauline, you talked a little bit about the disability and the not wanting to depend on anyone. What kind of disabilities are found because are there different levels or?
Yeah, it depends on the symptoms and the signs of stroke. So most people are aware of the symptoms of heart attack, for instance, chest pain, chest pressure, shortness of breath, nausea, dizziness. And part of Pauline and my job and our colleagues at the hospital and healthcare across the country is to inform people about the signs of stroke. because the signs of stroke are so much more variable, so it's harder for patients to recognize. And the key with stroke is the sudden onset of symptoms, where 1 minute you feel perfectly normal, and then the next there's a significant difference. And the signs and symptoms of stroke depend on the part of the brain that is affected. So for instance, common stroke symptoms would be weakness on one side of the body, numbness on one side of the body.
Either or?
Correct. So one half of the brain controls the other side of the body. So for instance, if someone had a stroke that affected the left side of the brain, they would have right-sided weakness or right-sided numbness, right-sided incoordination, as well as other symptoms such as inability to speak, where people know what they want to say, but they can't get the words out, or severe slurred speech. And if you have any of those symptoms, along with a severe sudden headache, that's when we're concerned about a hemorrhagic stroke or bleeding into the brain. So those are some of the more common presentations of stroke, but it can be quite variable person to person.
So would it necessarily be combinations of those things, or you have to have all those things at once?
It could be one of those things, or it could be a combination of many. Oftentimes it would be just weakness on one side of the body, or inability to speak, or sudden blindness in one eye in particular. These are all signs of stroke, and oftentimes symptoms can be somewhat subtle, and oftentimes they can go away. So people can have symptoms that come on, they last 5 or 10 minutes, and then say, oh, they went away, I'm sure it can't be anything serious, but that is a medical emergency. That's what we call a TIA, or transient ischemic attack. So stroke-like symptoms that come on and get better in a few minutes. And as physicians, that's the time we need to intervene. Now's the time where we have to focus on all of your risk factors so we can prevent those symptoms from coming back and being permanent or a stroke.
So for viewers that are sitting there thinking, oh, I had that funny feeling, or having trouble with those words coming out, the natural inclination, especially in different generations, is to poo-poo it and say, oh, well, I'm good now because it went away. Or so the message to them would be, call somebody or follow up.
If you have sudden onset of stroke symptoms, including anything where one side of the body feels different than the other, sudden onset of weakness, numbness, clumsiness on one side of the body compared to the other, or difficulty speaking, changes in vision, if symptoms start and they persist, or if they go away in a few minutes, these are both medical emergencies, so they have to call 911.
That's good to know, because I'm thinking go away in a few minutes would be
good news.
Yeah. Yes. Okay, I'm good. I don't have to call anybody.
And it's great news, but it doesn't mean it's still not an emergency.
Something bad isn't happening.
Correct.
You know, as Dr. Markowski said, you know, the symptoms with stroke are so varied, and it has to do with where the stroke occurred in the brain as to what the deficit, as we call it, will be, what changes that the patient will feel. The Massachusetts Department of Public Health launched a campaign a few years back. They've been working very hard in the state of Massachusetts to improve stroke, care and to help the residents of Massachusetts. And they launched a FAST campaign, TV and paper media campaign to be able to help the public recognize stroke symptoms in a simpler way. Because over the years before that, we had these long, posters with long lists of sudden changes in, and it was hard for people to be able to remember all of that. Again, the key message on that aspect is suddenness. But what they added to that with the FAST campaign is that by the word FAST, face is what the first letter stands for, and face is to ask the person to smile and see if they've lost the symmetry of that smile. If the smile is off, they can't, have a balanced smile.
Right.
The second one, A, is for arms, to ask the individual to see if they can hold out their arms, and if one of them drifts off, that they can't hold it up, that they've got a weakness on that side. And it isn't limited to arms, it could be legs, but again, the concept of the extremities and do they feel weakness somewhere? So that's just a good test to give someone. Right, and then the letter S stands for speech. Is there any alteration in their speech? Is it hard to understand? Is it garbled? Is it not making any sense whatsoever? Or sometimes they're able to speak, but they can't understand the person speaking to them. So speech, the concept of communication. And finally, the letter T in FAST is for time to call 911, because the campaign was really about getting the public to realize that getting help immediately is what's critical. So FAST has been, I think, a very effective way that the state has rolled out this means to help the public understand.
To remember.
A quick, easy way to remember it and kind of narrow it down for all that detail.
Right, that's great. And then it is 911 at that point.
Absolutely.
Is that right?
It
Don't wait
is.
till Monday to call you. right?
Absolutely. And don't try to drive yourself into the hospital. Don't wait to call your doctor's office. It's a medical emergency. And the sooner that you're evaluated, the sooner that we start treatment, the better the outcome, not only in the short term, but in the long term.
Okay. What about prognosis for patients with stroke?
Yeah. It really depends on the symptoms they begin with. It's a matter of what part of the brain was affected, causing those symptoms in the first place, and how large a stroke that they had. Strokes can be relatively small, and even a small stroke can cause pretty debilitating symptoms, or strokes can be larger, but it depends on the part of the brain that was affected. So it really has to do with the symptoms they begin with, as well as the extent of brain injury will determine longer term, do people have residual symptoms? And 30% of people who suffer a stroke will have some degree of permanent disability afterwards. And that can range to any degree of numbness on one side of the body, weakness on one side of the body, difficulty walking, difficulty speaking, again related to what symptoms did they have initially when they presented. And the good news is with time, a lot of these symptoms get better, and most of the symptoms improve over the first 3 months. And after 90 days from a stroke, that plateaus a little bit, and people don't have the same degree of recovery. But all the more reason why we need to evaluate and start treatment early after this happens to put the odds in their favor that they'll have less disability and have a good outcome long term.
Yeah.
I'd also like to comment that we're very blessed on Cape Cod and the islands for our EMS service that we have here, and that they really are very knowledgeable, very skilled. They're fluent in the stroke protocols. They're attentive to recognizing stroke and notifying the emergency department very quickly. The goal to get that patient in to be able to provide treatment as soon as possible. And I believe, if I'm not mistaken, May is also EMS month, so we can give them credit.
A good combination.
Yes.
Indeed.
But over the years, I've worked very closely with our EMS service, and the EMTs and paramedics are just outstanding in the work that they do.
Nice.
And understand fully well that time is critical in the management of stroke, so
Very
they get our
good.
patients to us very quickly.
So I'm going to circle back to very early when we first started talking, and we used the word preventable. When you think of, this is one of those things that with a little better self-care could be preventable.
Correct. You know, unfortunately, there are some non-modifiable risk factors that I mentioned: age, gender, ethnicity, heredity. But in large part, stroke is a vascular disease. It's a disease of blood vessels. Just like a heart attack is related to a blockage in the heart arteries, a stroke is related to a blockage in the brain arteries. So there was a movement a few years ago to start calling this brain attack rather than stroke, because that's essentially what it is.
Yeah.
And because it's a vascular disease, the risk factors are very similar. So high blood pressure is the number one risk factor for stroke.
Is that right?
Correct. Along with that, diabetes, which is getting increasingly prevalent in our U.S. population. High cholesterol as well. After a stroke, we need to make sure or if people have several risk factors for stroke, we have to make sure that bad cholesterol, that LDL, is as low as possible. We want that bad cholesterol, the LDL, less than 70. And then smoking.
Has that changed? The LDLs and even
They have gotten stricter and
Correct.
stricter over the years.
it seems
That's
like some of those
the Heart
numbers have
Association for a long
lowered
time.
down.
That's
Okay,
right.
yeah.
Just even the blood pressure parameters,
Yes.
as well as the cholesterol guidelines, they keep pushing them down because, again,
Is it because of things like this?
because of the
what we're
magnitude of the
learning and
disease that follows,
the
heart
knowledge,
disease and stroke is just so huge in numbers that, again, trying to get a healthier population for self-care that's going to make a difference.
And then lastly, smoking. And it is never too late to quit, because if people stop smoking, within 2 to 3 years, their stroke risk decreases as if they never smoked a day in their life.
Really?
So it's never too late.
That's great. That is really good news, because you do see a lot out there.
Yeah.
Right, and a lot of people think, oh, I've been smoking so long, what's the use, why
Yes,
quit
the damage
now?
has been done, and
But
it's
even
not
with
going
every
to get any
active
better.
cigarette, the constriction of those blood vessels occurs. And, we always say you're robbing, the valuable oxygen that should be getting to those cells is being replaced by carbon monoxide. So, again, even that cigarette you just put down and decided decided not to smoke has already helped you.
Yeah.
So it's worth it, definitely.
Do you get into talking about secondhand smoke in this circumstance too, or is that?
Somewhat. The data is a little more unclear, but
Okay.
we do know there are risks with secondhand smoke as well. It's not nearly as great a risk as primary smokers, but there is a trend in multiple studies, not just for stroke, but also for heart disease.
Right.
So.
Can we talk again about, so the numbers again for blood pressure was
Now it's 140 over 60/70 for the parameters that their guidelines are to push it.
okay.
But we even see them publish, American Heart published, that if someone runs a blood pressure 120 to 140 for the upper number, that's pre-hypertension. They're getting to a point of really wanting us below 120. So they're pushing it all the time. I know. A little meditation for all of us, right? Exactly.
we're not checking people.
It's not easy because, you know, with age also increases, blood pressure goes up, you know.
Automatically just because of age? Because
My
things
mother
are
ran a
stiffer
blood
and-
pressure of 80 over 50 her whole life. And one day I get a call from the emergency department. She was in her 80s at that point. My parents had moved to the Cape. And I get a call from the physician there and said, your mother's in the emergency department with malignant hypertension, meaning it was a very dangerous level. And I said, no, well, first of all, I said, it can't be my mother. My mother runs a low blood pressure. And I said, well, how high is it? You know, and he said, 220 over 110. I said, then are you sure it's my mother? You know, and it was a little French lady who, you know, claims to be your mother. She's 4'8". I said, that's my mother, all right. And so, you know, again, my dad's a retired physician, and we were kind of, you know, just beating ourselves up, saying a nurse in the family, a physician in the family, how can we let this happen? We should know better. And really, I think what happened over time is that as it was creeping up, and it didn't look anything to get excited about at 120 or 140 or 150 even systolic, because other people in the office perhaps are at 200. But all of a sudden she found herself with very significant hypertension. So with age increases blood pressure. So I think we all have some work to do as time is passing for us.
So as a follow-up to that, then people probably now are checked annually.
Oh, right, regularly, yeah.
Yeah, is that
Hopefully
enough?
more frequently than that.
annual, yeah.
No,
They
no,
should
more,
be more.
more so than once a year.
Especially
at
if
least
there's
twice
some-
a year.
If you have the age factor or there's some other factors involved, then one should be checking it more
Correct,
frequently
because
than that.
we want to prevent strokes before they occur. And as soon as we can intervene with high blood pressure or any of these risk factors, the better the person will be long term, because we're lowering their risk of not only stroke but heart disease.
Okay. Now, TIA, you touched on it a little bit.
I did. So TIA stands for transient ischemic attack, and what that refers to are stroke-like symptoms that come on and get better. And the classic definition was symptoms that get better within 24 hours. But now we know with research over the past decade that most TIAs last 5 to 10 minutes. And if symptoms last beyond an hour, even if they go away eventually, when we order an MRI of the brain, a good brain imaging study, we will see an injury to the brain or a stroke, even though their symptoms went away. So this is the time to intervene to prevent this from happening again.
Right. So believe it or not, we just have a few minutes left. Time flies when you're having fun.
Yeah.
So I want to be sure to touch on what it means that Cape Cod Hospital and Falmouth Hospitals have the designated stroke center from the
We
Public Health.
we launched at Cape Cod Hospital our stroke program in 1997 and organized our treatment protocols and had a stroke committee that reviewed all the stroke cases regularly, much of what we're still doing today. But the Massachusetts Department of Public Health launched a campaign in 2004 introducing the concept to hospitals that they were going to designate hospitals as stroke centers, as primary stroke service hospitals. And so we had our survey, which went very, very well because we were well prepared with the background work we had done. We became a stroke center in 2005, and as well as Falmouth Hospital becoming a stroke center. And then through our work, through all those years, we're very proud of the fact that we've been recognized by the Mass Department of Public Health and the American Heart Association for the Gold Plus awards that we've received in 2011 and 2012, which are the highest awards that we could receive for our stroke programs.
Nice.
So we work very hard at it.
Congratulations.
We work at it every day.
That's
Thank you very
great.
much.
Really
And
great.
yes, and with that, again, just very motivating to be able to continue to do the work that we do to be able to ensure that we provide the best stroke care we can for our
So
patients.
what does it mean for the residents of Cape Cod that it has that designation, that they're fully comfortable to go to those hospitals? And
We have
That's
all of
exactly
the
right.
appropriate treatments that are available. The only exception is something called interventional TPA, which requires an interventional neurology service that just the teaching hospitals typically have. But the majority of the care for stroke is really done just the way that we're providing it in these two hospitals, and we're very
Nice.
proud of that.
Exactly right, and because Pauline mentioned TPA, there's only one medication FDA approved for the treatment of stroke. And this TPA for the treatment of stroke has been available since the mid-1990s. And the reason why we keep saying stroke is a medical emergency is TPA is FDA approved to be given within 3 hours of onset of symptoms. Now it can be used in off-label use up to 4.5 hours, but time is brain, and the sooner patients get to the hospital and the sooner we can evaluate for this treatment, the better they're going to be. Because every minute that goes by when a stroke starts, over 2 million brain cells die. Now, fortunately, we have a pretty good reserve. We have about,
So how many do we have left after that?
have about 100 billion altogether. I'm sure you and Pauline have even more than that. But every minute that goes by, there's more brain injury. So we need to intervene, and we need to see if patients are candidates for this medication that's only given in 4 to 5% of patients nationwide.
Wow.
Predominantly, the number one reason for that is because of the delay, that patients delay to call for help.
Yeah, so
and
it goes back
that's the major
to-
reason. So recognizing symptoms, something's just not right, call 911 and get in there. And that at least opens the opportunity if the patient is appropriate to receive this treatment. Not everyone is, because there's some bleeding risk, significant bleeding risk
Right.
associated with this treatment. So
But you won't know
as they're
until you go in.
evaluated by
Correct.
the paramedics and then the emergency room physician, the neurologist,
Right.
then if the patient's a candidate for the treatment, we're going to be very happy to give it to them.
Great. Any last thought, anything we haven't touched on that you will drive away going, oh, I wish I would have said, I wish I would have told them?
Well, I think my main focus is just increasing awareness of the symptoms of stroke, because again, they're so variable that it depends on the part of the brain affected. So people just don't recognize these symptoms as stroke, as a brain attack, as
Yeah.
brain injury. Any sudden onset of symptoms where one side of the body feels different than the other, and that's a medical emergency.
Very good. All right. Thank you both for being here today and
very much.
sharing
Thank you very
all
much,
your wisdom.
Jeanne.
That was very good
Appreciate it.
information. Yeah, I appreciate it. And I'm Jeanne Sarnosky, wishing you good health and good health care.